Okay, I would like to begin with an introduction to our speakers. And today we have Judy Song. Judy Song is a fourth-year nursing student. She'll be graduating from St. Lawrence College in December, receiving a degree from the Bachelor's of Science of Nursing program, which is the first college in Ontario to be granted accreditation by the Canadian Association of Schools of Nursing for a standalone BSN degree. Judy decided to pursue a career in nursing during COVID-19 after seeing the lack of resources and support in the long-term care facilities. Her current placement at Lanark, Grenville, and Leeds health units allows her to develop her understanding of how systemic factors affect holistic health. She hopes to continue working with the vulnerable populations as a registered nurse. And our congratulations to Judy, because we understand that she has completed her year and is now excited to be joining the workforce. That's very exciting. Congratulations, Judy. Debbie McIntyre is a registered nurse working as a cessation coordinator at the Leeds, Grenville, and Lanark District Health Unit. Debbie holds a Bachelor of Science degree in nursing from University of Victoria and has 23 years of experience working as a charge nurse in long-term care and 11 years working in public health. In 2023, Debbie fulfilled the educational practice and written exam requirements to become a certified tobacco educator. Lucia Taggart has been the BPSO lead for the LGHU since 2017 and continues to interject BPSO possibilities into her role as nursing practice coordinator. She's completed her RNAO ACPF on the topic of what compassionate care looks like in public health nursing. Lucia spends her time as a life coach for her 4 children, 3 cats, 2 dogs, and just 1 husband. We welcome both Lucia and Debbie here today. Thank you very much for joining us. We look forward for your presentation. I will hand it over to you ladies, and I will grab some water while I do. Thank you very much.
Thank you very much, Julianne. I'm very happy to be here with Debbie, and yes, you just have to make eye contact with me, and all of a sudden you're presenting at a Champions webinar, so that's wonderful. Judy actually isn't able to be with us today, but she was an integral part of this project that Debbie's going to be talking about. So we thought she should get credit. Plus, it looks good on your resume, as I say. Alrighty. Oh, do I have? There we go. So, for those who don't know, Lanark, Leeds, Grenville, we are located on the traditional territory of the Anishinaabe, Huron-Wendat, Oneida, and Haudenosaunee, St. Iroquois peoples. And this territory is covered by the Upper Canada Treaties. So that's us, Leeds, Grenville, Lanark Health Unit. We have our main office is in Brockville here, and we do have our second main office is this Falls. That's where Debbie and I work out of. And if you need to know where we are in relation to Toronto, because you know everything happens in Toronto, we are east of Toronto, so you can see us right there. So we're between Kingston and Ottawa. Excuse me, our population, we're about 189,000 people, and we are considered a rural environment. We have 22 villages, towns, cities, and townships. And as you can tell by the stats there, that a lot of our people are a little bit on the older side, and so which is great to know that to know our community and the services that they need. It presents some challenges, but also presents some wonderful opportunities. Just a little bit of our BPSO. We were designated in 2017, and we were one of the first, only 3, I believe, or 4 health units to do it. We've officially implemented 10 BPGs across the agency and programs. I say officially because we have taken parts of a lot of the guidelines just haven't done them, put them on our work plan as official. We have provided 3 fellows for the Advanced Clinical Practice Fellowship Program. As Julianne mentioned, I am one of them. Conference presentations, Debbie here at my side has actually done a couple of those, so that's wonderful. And Debbie and I are working on a manuscript based on the project that she'll be talking about. Again, she didn't know that when she signed up, but you know, why not? But we have one already has been accepted for publication. So lots of opportunities in the BPSO program for sure. So that's just a slide of showing some of our products through because of BPSO. Our tagline is excellence in action, and then you can see there's Debbie and Catherine, one of our nurses at one of their conference presentations. Down here we have actually Catherine Wallace is a coach with some of our former staff who actually Tennis actually received an award from RNAO for excellence in leadership. And then the Infant Sleep was one of our pamphlets or resources we produced based on BPSO. And the latest picture is the one up top there when Dr. Doris Grenville came for a visit on the fall tour. We were thrilled that she was able to be with us. So, alrighty, so that's a little bit about us. And oops. So we'll get on to the presentation. I know Deb is just dying to do it.
Thanks, Lucia.
I've lost the ability to advance. Could someone advance the slide for me?
You can just press with your mouse one time.
Oh, that's right. Where is it? Oh, dear. There we go. All right, so calling this Nicotine Free Without Feeling Stigmatized Outreach Quit program. Take it away, Debbie.
All right. So next one there. Okay. So we all know this, tobacco use is the leading prevalent cause of premature deaths in Canada. One of the reasons and one of the things that we talk about a lot is that when you inhale nicotine, it takes about 10 seconds for that nicotine to reach the dopamine receptors in our brain, which produces that feel-good feeling. The more nicotine you use, the more your body craves, the more those receptors become blocked, and then it becomes kind of the only way that our bodies can produce that feel-good feeling. So even though we know it's a leading preventable cause of death, that's why it's so hard for us to make those changes. So impact on priority population. So this is a population that we worked with are the homeless or those that are underhoused or not stably housed. They have the highest rates of nicotine use. Usually the hardest for them to quit is because the addiction does require some support from health professionals, many of our priority populations have kind of lost connections with primary health or trained people to help them navigate. And they've lost trust, just given the situation and the things that have happened to them throughout their lifetime. So the impact on mental health. So it's always an interesting one. Mental health and addictions often are directly related. The prevalence of nicotine use is highest in people with mental health issues. One of the things that can happen is that there's a big reluctance for healthcare providers or other professionals to address nicotine use. They don't see it as the biggest problem, the biggest hurdle they have to deal with, and so often the conversation is left untouched. But we do see that up to 90% of people with schizophrenia are using nicotine, 70% with mania, 49% with depression. The other interesting factor there is the link between anxiety and depression. They are definitely worsened by the use of nicotine. Also, many of the medications that are used to manage chronic mental health conditions are also impacted. The metabolism is impacted by the use of nicotine. So it is one of the things that, even though it's hard to have these conversations, it really is an important conversation to have. So this program was built, really what we wanted to do was to create a community to increase confidence for community partners to have these conversations, to feel more confident, to have some of the answers, also to remove some of the barriers for accessing NRT. NRT, or nicotine replacement therapy, is very expensive. When you look at it, cost for health and, cost of buying it versus buying cigarettes, it's not quite as expensive. However, when people have the choice between buying cigarettes they know has worked quite fine for them in the past, or buying nicotine replacement, they typically choose buying cigarettes. They also have different barter systems, ways of getting cigarettes, so the cost is a little bit different for them as well. So we wanted to kind of build this capacity for trusted community partners to have conversations about nicotine education. One of the other big things that I often will talk about as a tobacco educator is, if quit's not in your plan or it's not what you want to do, could we talk about a reduced plan? We all know that there is no safe level of tobacco to use, but a reduction certainly does improve symptoms for those living with chronic conditions as a result of tobacco use, or vaping, or any other type of nicotine. And my hope is always that it will lead to increased confidence to make an attempt at a full quit. So we also wanted to increase the capacity of the outreach people to know, that are supporting, to know how to refer. And we wanted to create a peer support for the community. So lots of things coming up about that. So in partnership, so we partnered with the Lanark, Leeds, and Grenville Addictions and Mental Health to look at some of the ways that we could help to remove some of the barriers. So one of the big things, I was already going to the drop-in, not necessarily to do smoking cessation, but just to be kind of the face of the health unit, to let them know what other services we provide. So I was kind of already going there, not really expecting that there was going to be a big uptake of people wanting to quit or reduce their tobacco or nicotine use. And that's kind of where it started. And then we slowly started saying, gee, I wonder if we could tailor a bit of an education or a bit of a group session to help the community to learn a bit more and to know about the access. Lack of counseling is also another big one when you're trying to quit. It's not an easy task. I often liken it to, having a gym membership. I mean, I have a gym membership, but that doesn't mean I go. Same with providing NRT without that counseling or without someone to help, doesn't tend to be as effective. Again, if I've got a gym membership and Lucia's got a gym membership and she shows up at my office door and says, hey, headed out to the gym, are you coming with me? I'm more likely to go. Same thing we wanted to be able to do with the nicotine replacement, is to provide that extra support to say, hey, how's it going with the patch, and how are you finding things, and reaching out when they need extra support. Yeah, so our program objectives were, they were, of course, to help to reduce nicotine harms, but a bigger part of this program was to develop stronger relationships and reconnect the outreach community back to just to society, to the philosophy and the idea of community and contributing. So if we wanted it to be done in a way that was shame and blame free, and we wanted to improve their overall quality of life. One of the big factors that we talked about too is when they're looking at housing, when they're standing there in front of a landlord who is potentially going to rent them a place to stay, which they need for housing, and they smell of cigarette smoke, or they look like they've been smoking, those landlords tend to shy away from renting apartments because there's, for fear of having them smoking inside and those kinds of things. So we tried to look at that whole thing to reduce the stigma around that and to help them to be able to improve their quality of life, give them a little extra cash to use too, hopefully, and to feel better, to participate in different things. So how did we reduce the barriers for access to the nicotine replacement therapies that we talked about being so expensive? We are affiliated with and are implementers of the STOP program, which is Smoking Treatment for Ontario Patients. So that's a publicly funded program that provides up to 26 weeks of nicotine replacement therapy and counseling. Eligibility is pretty simple. Have to be using some form of nicotine that includes vape, combustible, smokeless nicotine or tobacco in the last 30 days. They have to reside in Ontario, and then we just have to register them to our clinic. So that was a big draw for when I pitched this idea of a pilot project to the Addictions and Mental Health group, because it makes getting the product easy. Also, we know where they are, so we can bring the product to them versus, you know, some of the other programs require NRT to be mailed. Many don't have fixed addresses. That's a little bit difficult. So coming to where they are. The other thing is many of the other types of counseling and quit programs have requirements to have a phone to be available for conversations about how things are going, where when I was showing up at the drop-in every Wednesday, they could connect with me because they knew I was there. So it reduced that barrier. Also, we know that the combination therapy of a patch for long-acting nicotine replacement, along with the short-acting, so lozenges, gum, or inhaler to deal with those cravings, is 30% more effective than using just a single form. And combined with counseling along with the NRT, you can really quadruple chances of people being successful in their quit attempt.
I saw a hand up, and I think, Jillian, I think we said take questions at the end. Thank you, because I don't know how to click it.
That sounds good. We'll take all the questions at the end and we'll let you ladies carry on. Thanks so much.
All right.
Okay. So I was chatting with Lucia about some of this stuff, and she said, "Oh, have I got the BPG for you?" And so, because a lot of what I was saying, you know, Lucia, as we know, lives and breathes this RNAO and best practice guidelines, and so so at first I was like, "Oh, here we go again, Lucia and her promoting of these things." But when she showed me this one, I was like, "Oh, this is exactly what I'm experiencing, what I'm seeing, what I'm feeling." And so we decided to try to use this to help to shape our educational series for outreach community. And we found it was actually quite helpful. So you can see there, it's based on the social constructivism theory. I loved I was already saying safe, shame, and blame-free environment, which is why we chose to do the program in a place where they already felt safe. The other thing that I really loved about it was a conversation around much of the education we do as nurses is health education provided, nurse provided this education. Whereas when I looked at this BPG with facilitating client-centered learning, it really made the focus more on nurse-supported learning, which I really loved. I just loved how that felt for this population and for many. No one wants anything done to them. They want to be supported to make their own changes. So I was already at the drop-in, so I was listening to the clients. I was establishing the therapeutic relationship. That was a bit tough at first. I probably arrived at the center probably 3 weeks in a row where no one even looked in my direction, let alone came and spoke to me. But I just partnered up with the addictions and mental health support staff and walked alongside them and let them do kind of the introduction to who I was. And then once I got that opportunity, then I was able to connect with them a little bit more. So the concepts of listening, establishing, adopting, reinforcing, naming, and strengthening really fit very well into those pillars of the work that we were already trying to accomplish. So speaking of those pillars, we kind of looked at putting this kind of gathering it up so we could organize it in our heads. So what the model looked like in practice for us was, for the pillar of ensuring client-centered care, we wanted to establish those goals that had meaning to the people we were trying to reach. The other thing was to work in a place they already were. The co-facilitator was huge because she had already built trust with them. She knew how programming worked. She knew how to incentivize. And when I say incentivize, we did kind of bribe them to come to some of our presentations, but they were happy to be incentivized. And we listened to them to let them tell us what were their goals related to nicotine. So yes, my goal is for them to quit and not use nicotine ever again, but that's my goal. That's not their goal. Maybe their goal is just to reduce for now. And we said that was perfectly acceptable. That's your goal. Next, we looked at promoting health literacy. So we tried to look at multiple ways of presenting the information that we wanted to present. So in one of the very first weeks, we did just a video about what is nicotine, what does it do to our brains, how do we become addicted to it. We looked at discussing about what the goals of this program should be. So initially they wanted to start out with just learning a little bit, but as we moved along through, they kind of started saying, hey, it looks like we might need kind of 3 different groups. So a group that we call Quit Curious, a group that is actively quitting, and a group that's looking to maintain. So that was just an interesting, and that we really looked at that as kind of fitting into both of those pillars with promoting health literacy and also building on knowledge and skill. So once they learned the skills of understanding the reason that they were addicted and the reason that they were using nicotine, then we could build on how do we change some of that? How do we substitute something new? Creating a supportive community and a supportive culture was also very, very big, and you'll see some more evidence of that later on when we get into what the weeks looked like. Supporting self-management, so again, assisting the clients to create their own plan. What does it look like for them? Connecting clients to the community. Again, going back to that co-facilitated piece of increasing the knowledge of the support staff so that they felt comfortable to answer questions. They always knew how to reach me by work cell too, and I would often get a call during the week with, where they would put, I've got Dave here and he's got a question about something, and they would put him on the phone and he would ask the question, we'd answer it. And then one of the other things that I would often do is almost like a teach back, where I'd say, okay, what did you learn about that? Can you tell Carrie what we talked about? And then listening to do that teach back. And they felt good about having that in knowledge and controlling it. So, all right, next one there. Yeah, so again, we looked at the spirit of motivational interviewing when we were doing this, asking those open-ended questions. You can hit that a few more times, it'll pop up some of our, so just open-ended questions. That began early on, just kind of establishing that relationship. Tell me how you like to learn about something. Tell me about experiences you've had with quitting. Tell me when you started to smoke and why you continue. So that was just that, kind of adding those. So then we developed the outreach program outline. So week 1 was just an introduction. We just wanted to talk about when is it going to happen? What's the expectation? How long are you going to have to sit here? All of that kind of thing. Originally, the organization of the agency wanted us to run the program in a classroom, which was away from the main part of the outreach. The co-facilitator and I decided that was probably not going to be the best option. So we chose to run the program right within the drop-in, which had a couple of different, we'll talk about the evaluation piece of that and the unintended benefits of that. So week 2, we did why do you smoke? Because anytime we're trying to make a change of any type, we have to understand why we do something. So we did a short quiz. I printed the quiz out, and then we were able to go through the questions. We read them out aloud, and then people answered and then scored themselves to get a sense of why did they smoke. Some smoked for social, some smoked because it helped to reduce their anxiety, which we'll talk about later as well. Some smoked because it was just social. It was just something that they've always done. Week 3 was on nutrition and water. So we talked about the importance of giving our bodies good nutrition. We talked about hydration, which also linked back to the 4Ds that we talk about in quitting. One of the 4Ds is drink water. When you're trying to manage or surf an urge or get through a craving, those 4Ds are important. So deep breathing, which we talked about in the next one, which is stress management. We talked about drinking water, delaying, and drink water, delay, deep breaths, and oh my goodness, what's the other one? Deep breath, drinking water, delay. Oh yeah, I
Do
know.
something else.
Oh yes, distraction. Thank you. Well, there's my distraction.
Right there.
There was my distraction. So finding something else. So thank you. So week 4 was stress management. So we talked about different ways that we could manage stress. We talked about the fact that physiologically, having a cigarette does not actually relax you. It physiologically causes your blood pressure to rise, your heart rate to rise. And it really does nothing. Your stressors are still there after you've had a smoke. So then we said, well, what do you think about the cigarette or the nicotine is helping? They said, well, sometimes we have to walk away from certain situations. We said, yes, exactly. Could we do that without a cigarette? There was some conflicting ideas of whether we could or couldn't. But we made our own stress balls. We with rice and balloons, and they made their own stress balls. I brought some googly eyes that they put on them. We put hair on them. We went all out with all kinds of hands-on type of things to do there, and they really enjoyed that. The other thing we did was blowing bubbles. So we took them outside to the courtyard with some bubbles, and they made the connection between blowing bubbles is very much like smoking, same hand movement, but it also encouraged the breathing and that kind of thing. Week 5, getting prepared. So again, when we talk about adopting as you go with the LEARNed model, this is one place where we had to adopt. I wanted to introduce the idea of planning to getting prepared for something. And so I went with the idea that we were going to talk about planning a party. So I got there and I pitched this idea, and one of the clients said, I don't want to plan a party. I want to go and watch a Blue Jays game. Okay, so we adopted, we said, okay, we can still work with this. So we said, okay, so if we're going to go see the Blue Jays game, what would we need to do? Same with quit planning. We need to pick a date. Well, we have to make sure that that date is a day that the Blue Jays are actually playing. Then we have to plan how are we going to get there. We got to make sure if we're going to take a train, then we've got to buy our ticket. And that also brought up some more conversation with them around, well, we don't need a ticket. We can buy one from the scalpers. And I said, well, you could possibly, but what if you buy the ticket, you get to the gate, and that ticket's not valid? So then they agreed that maybe being a bit more prepared with an actual ticket would be a good. So it was just kind of trying to make that connection around the importance of planning if you want something to be, if it's important and you want it to be successful. Week 6, we talked about the day evening treatment program that is programming that is run through Leeds Grenville. So we wanted to connect them back to the organization they were already accessing. And they had some great programs in there. They had some really good day evening treatment programs. Cognitive behavior therapy for dealing with anxiety. They had substance use 101. They had a whole list of programs. So what we did was we invited the presenters, the people who do the coaching of those programs, to our week 6 session. And they talked about their programming, and it was just a nice kind of a warm handoff to the other programming, the other supports that were there to help them with other life skills to manage all kinds of different things. And I think it was helpful for the clients to see Carrie, the coach, and myself interacting with this other group that they had no connection to. Even though the buildings are attached, they had no connection to. And I'm going to talk about it, another happy accident that happened with that as well, near the end. Week 7, we talked about facts and myths, because anytime you talk about smoking and NRT, you've always got to dispel those myths. The ones around, oh, you can't smoke if you've got a patch on, you'll have a heart attack and die, which is untrue. That NRT, if you're using it, will take away all your cravings and you're going to feel great and you're not going to struggle, also not true. So some of those kind of things. So we talked about kind of what does that look like? What are the myths? What are the things you think you know? And then provided the information. And then the last piece was around the evaluation. So you can go to the next one, I think, there, Lucia. Yeah, so this is kind of the evaluation piece, and this was kind of our participant feedback, and we tried to feed it back into those pillars again. So these are the things that we heard. You know, I've been smoking for 45 years. Is there any point in me quitting now? Always a famous question that I get. I will tell you, this one participant was a little disappointed to hear that it could take up to 10 years for his lungs to kind of, you know, recover from all his years of smoking. But anyway, that's the facts, and I didn't try to sugarcoat the facts. The facts are the facts. You've done this damage and whatever, but we did talk about those shorter benefits that you're going to see earlier. The other thing, they really were very thankful for explaining why it was so hard for them to quit, and that it made sense to them from an addiction standpoint, and what happens to their brain. The promoting of health literacy, they often would ask, you know, all kinds of questions about that too, like, you know, how long does it take for my health to improve? So if I'm addicted, it's going to be more difficult for me to quit without using NRT. Those kinds of things. They gave us great feedback on what they liked as far as the videos, the handouts that we gave them, just different ideas around snacks. So when we talked about nutrition and water, we showed them kind of some healthier choices that they could make at the dollar store when they've got limited funds. We also gave them little packaged up, we bought them water bottles at the dollar store for $1.75, so they could refill their bottles to take with them. We also talked about, when we talked about promoting health literacy and understanding things, we talked about the importance of water, not run through coffee grounds, because that's just typically how they like to consume their water. So, and then we talked about saying, you know, if you've had a cup of coffee, to have a drink of water in between, those kinds of things. The building on knowledge and skills, they also really enjoyed being able to make the connections back. So at one point we showed the video, and I don't know if you remember when we first started this, I told you how many seconds it takes for nicotine to get to your brain when you inhale it. And I asked the question a little bit later, and even someone from over the wall who wasn't even participating in the group knew the answer. So we knew that people were listening in and building on some of those skills, even though they weren't necessarily participating. And then the other big one that the kind of unintended one that we didn't expect would get as much uptake as it did was the creating supportive environments. So they really talked about how the culture there affects people's ability to be able to quit. So they really talked a lot about, like, it's pretty difficult when I'm trying to quit and everyone's sitting right outside the door, that I have to walk through a plume of smoke to get in to access things. So there was a conversation around what they could do and how they could advocate. Was very interesting. One of the clients who wasn't even in the group per se, only had come to one session, the next week when I showed up, I saw him outside with a broom and a dustpan sweeping up all the butts. I said, "Oh, look at that. I mean, thank you very much. That looks great." And he said, "Well, I'm just trying to help out my community. It can't be easy for people to look at cigarette butts out here." So, you know, and that's always incentivized by me. I've always got a bag of things, and I reached in and I think I grabbed him a pair of sunglasses or something like that to incentivize his effort. And it was appreciated. It was appreciated by the other members of the community as well. The other thing they did, they moved the bench and the butt cans further away from the door, which was also, I think, a great supportive strategy that they took on themselves. Yeah, so this is just some more participant feedback. So the clients liked the location, the structure, they liked the timing. That was the other thing we talked about too, is we wanted to make sure that when we scheduled the sessions, we were mindful of the other activities that were going on. And we didn't want to interrupt bingo. We didn't want to overlap into the time that they are required to get ready to get transportation back to the cooperative care center, which is the homeless shelter for the night, because that causes them anxiety as well, worrying about missing their transportation. They loved all the anything we did that was interactive. They loved the information about the healthy food choices and the increased water, increasing their water. They've got a cooler there anyway, and I see it's been used a lot more than it was, and I see a few of my water bottles still kicking around. Oh yeah, this was one of our clients that participated. He joined us in week 2, I think, and by week 3 or 4, he had already been weeks, or days of smoke-free. I think 28 days at one point. And he said, you know, at this point, I might as well start counting my number of smoke-free, you know, in weeks, not days anymore. And that was great. I mean, that was very encouraging. Yeah, so in total, we had about 8 to 12 participants per session, but again, always on the fringes, we had some extras that were listening in. We had 4 enrollments to the STOP program, 2 of which are still successfully working their way through, so that's pretty good, 50% is pretty good. 1 referral for a STOP, another location that's a group home that's supported by Lanark, Leeds, Grenville, that wants us to come and speak about what we can offer for help. And again, as I say, we saw some behavioral changes. We saw those that chose to continue to smoke to moving further away from the door and not being quite so close, not offering each other cigarettes. As Mike said, you know, I don't want anyone to offer me a cigarette anymore when I'm working so hard. And even if I ask, I want them to tell me not to. And so I said, well, you need to tell them that. Speak up, say that. So that was the behavioral change that they felt more comfortable with. So this stuff, I think we talked about what worked well. Oh yeah, scissors for NRT, who knew? So that was certainly a real challenge we had to navigate when we provided NRT to the clients, because those packages you cannot open without a pair of scissors. They don't have any tears, so you've got to have, so we started handing out, you know, small pieces of scissors, or those, you know, those little plastic things that you cut the milk bags with. So I started carrying a few of those. The other thing that we worked out with LLG and with the Cooperative Care Center, the shelter, was that they could leave stuff there so they weren't having to carry and cart all of their stuff because they were worried that they were going to lose it, which is a very real possibility. So they left things at places where they were able. We also, the fluid structure was also good. We didn't insist on people attending week after week. You could attend where you wanted to. And then I think the rest is just a few more.
Oh, sorry.
That's okay. No, that's fine. Oh yes, the unintended thing I wanted to tell you about. So the day evening program is now looking at incorporating the LEARNS model and the client facilitated learning in some of their programming. So that's unheard of for them to actually come and provide their services within the drop-in center. That's new. It's uncomfortable, but they're getting much better. They're getting much more comfortable. And often they'll say to me, hey, can you come with me as well? And that's a helpful thing too, where we're still connecting and co-facilitating, even though it's their programming. So good. And then I think, yeah, the rest are just some participants' quotes, which you can read. And then that's, I think that's it for me. Just flip that. I think there's one more. Oh yeah, this one was fun. Yeah, this was fun. It reminded me of time when I was younger. That's when we were making the stress balls, and they just loved it. They really enjoyed the craft part of things. The other thing we did is I took a foam frisbee and we went out and threw the frisbee around for a while, and that was just, and the laughing and the fun that they had in that was. And one of the participants actually said, well, now you wasted 30 minutes of my time. I missed 3 cigarettes, and I said, great. That's terrific. And then this is Mike, as the hike on Sunday was great. He had a lot more energy now that he had quit, and he really found that a great benefit. So he was one of our greatest supporters. He went around telling everybody about how great the program was. And that's it for us.
It's amazing. Thank you so much, Debbie and Lucia. Your passion is just really shines through as you're talking and sharing stories and talking about the program. Thank you for your time for that. I love how it's titled A Safe, Shame, and Blame-Free Environment. I think that's so important and very client-centered and very community-focused. So I would like to open it up to those who have joined us this afternoon. If you have any questions, we'd like you to reach out in the chat there. We might end up going a couple minutes over time.